Much like John said, it would be much nicer to see everybody in person. Hopefully you'll get something out of this. I plan on speaking for about 40 to 45 minutes. Hopefully we'll have some time for some questions at the end for this part of the visiting professorship. These are my disclosures, and a very relevant disclosure to this talk is that I do receive royalties on the vertebral body tethering product. I don't have to tell everyone in the audience about Shriners Hospitals for Children, but just in a nutshell, it was my first job out of fellowship, and I truly believe in the mission, and it is truly an incredible network of hospitals in Philadelphia. We have 12 full-time physicians. Myself and Scott Cozen lead up the physician group, and an incredible group of surgeons at a great, really good hospital. And speaking of great hospitals, I don't have to tell you guys, the residents, fellows, everybody should be so proud of what you guys offer there. And I'm not going to get into the list of everyone that's there, Dr. Saltzman, Brodke, Heflin, but it really is the who's who of orthopedics. And right at the outset, a big thank you to obviously John Smith. Kristen Carroll is a leader within our hospital system who's really helped to enact several great changes for us. And you guys are very lucky to have her. And of course, John, I mean, what do you say about someone who's been a pioneer for what we do in the pediatric spine space, whether it was from his vector work to his leadership roles? And the best part about both of them is they're just great surgeons and great people. I mean, John is just truly at heart an honest, hardworking, great surgeon who likes to have fun. All righty. So why don't we kick it off? And I thought I'd just spend a couple of minutes on where we are today. We recognize that we've come a long way. We can take kids that have severe curvatures in their back, that have implications for their internal organs, their pulmonary function, perhaps cardiac function, as those curves get large. And through our understanding and improvement in implants and neuromonitoring, we're able to get these children into a really good place, right? So we have made tremendous strides in what we're able to do for kids in a safe, effective manner. But it still begs the question that there's so much more that we need to do. I mean, why does that curve have to get to be, 100 degrees? Why can't we prognosticate and pick these kids up who are going to progress early? And we are doing some work with our Portland Shrine on a biomarker. Of course, understanding the spine in 3D, right? We're using these two-dimensional representations. We've got to understand 3D better, and then growth modulation. Why can't we take a curvature or a child's growth remaining and help that spine correct itself? And that's really been the impetus for our work here. Why would we even want to consider growth modulation? You've seen certainly radiographically and the outward appearance of our results today, they're pretty good. We can make these kids a lot better, but we have to continue to do better. When you fuse a child, maybe there is going to be greater degeneration later on in their life, especially the lower we work down into their lumbar spine. Perhaps we can do better in the sagittal plane, although quite honestly, as I'll show you later with growth modulation, I don't think we're quite there yet. But of course, trying to leave a mobile spine, which has its biggest implications as we fuse lower and lower in the lumbar spine, but maybe there's a subset of children who do need that thoracic motion as well. And again, we will touch on these topics as we move through this talk. Let's just talk about where we have come from, right? I mean, in the 1930s, 40s, and 50s, a lot of preoperative traction, which I find interestingly, and casting, which has made a resurgence, right? We're using traction and casting much more currently as well, but we're using it in combination with our improved implants, our neuromonitoring. But back then, these patients were spending 6 months in the hospital. They were being operated on through a cast, limited correction with very high reoperation rates. So then there was a sequence of improvements that were made. You know, we had CD instrumentation, we had hooks, we had anterior approaches, then eventually, which led to posterior screws, which has really been the mainstay for about 20 years now. And the one thing that I really want to get across to everybody, PSF remains the gold standard. I mean, we can now, through a posterior approach, get good results safely with long-lasting implications, with long-lasting results. But the question really is, if we stop here, if we don't innovate, and we're doing the same thing 10 years down the line, 15 years down the line, are we still making progress? And that's been one of the impetuses at our hospital, is we want to continue to make things better, because we want to be able to, patients want options, and we want to reliably be able to provide those options. So when you have a child with a curvature such as this, there's going to be a subset where this is going to be the better option. You get a radiographically great result, good result, that's safe. It's most likely going to be a single stage surgery, although if you look at our long-term data through our study groups, the reoperation rates for PSFs is about 2% at 2 years, 5% at 5 years, and 10% at 10 years. But there may be a subset of patients, and again, it's about providing options where this is the better option, where you're able to come on the convex side using the Hütter-Volkmann principle, compress, limit growth, and over time, those patients are able to correct their spine. But this comes with its own downsides. You're likely to need a second surgery. It's been around, really 5 to 10 years. We've been doing it about 10 years. Most other centers, maybe 5 to 8 years. So there's limited follow-up, higher rate of reoperation. The patient, we just have these discussions and we can come up with what the best option for that particular patient is going to be. The concept of utilizing remaining growth, right? This is not a new concept. We know in bow legs, knock knees, we're using growth modulation techniques. Certainly in orthodontics, right? Bracing. We can rely on more pliable teeth and the ability to modulate those or get correction over time. And then certainly, neurosurgery, the plagiocephaly or flattening of the occiput is very amenable to using orthotics to help us get correction. Now, tethering is not our first attempt at growth modulation. My mentor, very good friend, Dr. Randall Betts, who truly is the pioneer in this space, had really come up with this idea. Why don't we compress the convexity with these staples, which were placed either through a minimally invasive approach or an open retroperitoneal approach, compress that convexity, allow the concavity to grow, and you're going to get correction. So this is what was being done at our hospital in the early 2000s. I started at the Shrine in 2005, and I did several patients with stapling. And what we found in 2007, 8, and 9 was that at our hospital, there was a greater and greater number of patients that were needing this, right? They were needing a posterior spinal fusion after their failed stapling. As I'll tell you later, the incidence of fusion after tethering appears to be about 2 to 3%. After stapling, it was closer to 30 to 40%. And what really drove it home for us was, it was not only the patients that we were operating on that we had at our hospital, but when our colleagues started calling us. I remember Dan Sakata giving me a ring, from Texas saying, hey, you guys have done a staple and we need stapling procedure, and now you need a fusion, and I now need fusion. What do I need to know, or anything I need to prepare? And then, the group up in New York, the same piece. And for the residents and fellows, what this should highlight is, subjectively, we can make our results, we can forget the bad results and really focus on the good, or just focus on the bad and forget the good results. You have to study your data, right? And that's what we ended up doing. Pat Cahill actually led this effort, where we said, why don't we look at what's actually happened with our stapling patients? And what we found, which ended up being quite consistent with what we were observing, we did this as a matched cohort with a group out of Switzerland, where we matched patients that had vertebral body stapling done with those that had bracing. And what we found was that for thoracic curves between 25 to 34 degrees, stapling worked very well. As we've become to recognize through the brace study, that's exactly the population that does well with a brace. So for those mild curvatures, stapling did well, but so did bracing. For the larger curvatures, once you got to 35 to 44 degrees, stapling really was showing a lot of progression with many of those children going on to fusion. And of course, the lumbar curves, the numbers in this series were small, but we could certainly anticipate that the results would be similar to what we had seen in the thoracic spine. And so at our hospital, late 2009, 2010, we really cut back on our number of our staples that we performed. And certainly once the braced study was published in the New England Journal of Medicine that showed the efficacy of bracing, we pretty much stopped doing stapling. But we were still left with a void, right? We can't just stop there. We have to still try to figure out, or we wanted to try to figure out, how we could get these children to modulate. And this is the SRS meeting that we went to in 2010. I remember it was in Kyoto, and again, just highlights how important it is to be able to meet in person, and eventually, hopefully, we'll be able to, because some of our best ideas or come out of discussing what's working and not working with people like John Smith, with people like Mike Vitale, Kristen Carroll, to be able to sit down around a table and say, hey, what are you doing? And that's exactly what happened here. We ran into, a surgeon who'd been doing a vertebral body tethering, a couple of them that were looking at it, and we recognized that there was perhaps a different option for patients. And that's how we got started in vertebral body tethering in 2010. We came back and found that there was a whole host of preclinical studies, right? That Peter Newton had done, and pigs and goats and others had done. So we used that as a basis. We really understood the biocompatibility of the tether and did our first patient back in 2010. Where are our current indications for this growth modulating procedure? Well, skeletal immaturity is a really important factor for us. And I'll talk more about this later, well, depending on how you define it. But generally, girls are going to stop growing sooner than boys, 11 to 13 years of age, boys 12 to 15. Wrists are up to 3, but vast majority are going to be 2 or less. Sanders stage, and I've spoken to Jim Sanders a lot about this, generally 4 or less, but we may go up to a 5. And then, of course, the curve itself, right? This is a procedure where we're relying on a rope to help us get correction. So we're not going to be able to do this on really large 75-degree stiff curvatures, although there are groups that are taking this on, and I'll show some slides a bit later. But for us, generally, it has to be a curve up to about 65, maybe 70 degrees. It has to have flexibility. And if it doesn't have flexibility, when I've tried it, if it's bending to 40 degrees, this procedure is not going to work in that cohort. And of course, the vast majority of these patients have failed bracing as well. So here's an example of a very typical child preoperatively. You can see 11 years old, has growth left. You can see her 6-month x-rays or 1-year x-rays or 4-year x-rays showing some sequential improvement. And we got these really neat pictures of her doing ballet and dancing. And we can even show some videos, right? Some really neat videos where you can see how well they're doing with motion. But where is the data to support this? Again, and I really learned this from our stapling experience, we have to go ahead and study, and I'm going to show you some of the studies we've done. And I'm sure there's many of you in the audience, as you rightfully should be, saying, I don't really know about that. And I'm confident that Kristen Carroll is definitely thinking, boy, sure, you showed a patient that can do flips and, can bend, but how is this really going to work? What do the long-term studies show? I've heard about breakages, and this is a flexible rope. Are these tethers going to break? You mentioned reoperations, right? How does that fit into this? And with respect to motion, if you're just doing the thoracic spine, how much of a difference are you making? Certainly, we can make an argument for the lumbar spine, but what about the thoracic spine? These are all great questions, and questions that I'm going to try to address as we move along. Well, as it turns out, there's been a plethora of studies that have come out, especially recently, from all different centers around the world, and you have to be a bit cautious because most of those are 2, 3, maybe 4-year studies. This is a procedure that really is going to need, until skeletal maturity to really be able to assess. And several different groups, there's different half-day courses being taught on this. We are really being inundated
with tethering results, a lot of which are good. And I always say you have to be cautious, because I can tell you, since we've seen follow-up, there are going to be some late failures that are going to show up as well. So we have to really understand who the ideal patient is, what are our success rates. Let me actually take you through some of the studies that we did. This was a study, so back in 2010 we start. This is a study we published, we presented at SRS 2015. We actually never published it, as I'll tell you why. Because the FDA eventually came in. So 2015, I present this study of 82 patients who were treated with tethering. Back then, certainly a very large number. We let these kids get to skeletal maturity, which was defined in the BRACE study, RISR 4, RISR 5. And you can see their preoperative Cobb angle was about 41 degrees, first direct at 20, and the most recent was 14 degrees. The results looked very reasonable. I can tell you today, our preoperative Cobb angles are going to be higher. The lumbar compensatory curve was showing, a similar correction. And I was feeling pretty good actually about this. And I remember one day I was sitting in my office and I got a call from the security guard saying, "Hey, Dr. Samdani, there's someone from the FDA that wants to chat with you." And I said, okay. I really had no idea what was going on at the point, because we've been using stapling off label for all these years. And they came in, they stayed at our hospital for over 2 weeks. They went through every single patient we had operated on. And I don't know if I was going to be in jail, if this was all going to be stopped. It was really unclear where things went ahead. Once they reviewed all the charts, they came out with a few mandates. They said, "Hey, listen, don't promote this. This is still off label. This is 2015. When you consent the family, we want to make sure you see all options." And luckily they saw all this in our notes. You have to tell them there's no long-term data and you cannot publish data, because that's going to lead to off-label promotion. And that's why this particular paper never ended up being published. And I was very distressed at the time, because these are very difficult studies to do as an ID. They're extremely expensive, although eventually the FDA did provide a great pathway, as I'll share with you later. So, let me just stop there for a minute or two and just let you know what I felt like. And obviously, you guys have a great basketball team with the Utah Jazz. They're great teams both today and in the past. I'm a Knicks fan from the late 1990s. So I follow basketball a little bit, but there's no one better than Malone and Stockton. And, what this felt like was very similar to the late 90s, when Michael, who put a dagger into our hearts and the Knick hearts many, many times as well, had that play with Byron Russell. But I can tell you for a fact, and I have proof right here, Michael definitely pushed off on that play. So you guys should have won that series. But anyway, so getting back to the project that we ended up ensuing after the FDA, they allowed us to prospectively follow our patients. The great thing about this project was they didn't have a start the prospective series, which would have taken close to 10 years to complete. They said, okay, these are the kids that you've done, and you can go ahead and follow these kids, bring them back and follow them out. And that really shortened the time to approval for vertebral body tethering. This study focused in on Lenke 1A and B curves between 30 and 65 degrees. We followed these patients all the way until age 18. Again, if the FDA really wanted to, they could have mandated that you start the study now and there'd be no approval. And all this actually led to an approval in August 2019. The demographics of the study that formed the basis of that approval, there were 57 patients, 86% girls with a mean age of 12 years. And the vast majority of these patients, as you can see from the Risser Sign Standard score, still had growth remaining. This is a key point. The follow-up in this series averaged almost 5 years. Again, when you look at other series that are going to be presented, those results may look better than they are because, firstly, the follow-up may not be as long as desired. And the vast majority of these patients had reached skeletal maturity. In the operating room, the number of levels tethered were about 7.5. The duration of surgery was 223 minutes. Typically, a thoracic tether today would take us less than 3 hours. Blood loss, there was a mean of 105, and they spent a day and a half in the ICU at our hospital, although today they spent about a day or so. And length of stay in the Shrine system, I don't think means as much, because especially when patients are traveling from afar, we tend to keep them a bit longer. And this is what our thoracic tethers look like. We can typically do them thoracoscopically through 3 posterior axillary incision and 3 anterior axillary incisions. The results from that study, again, preoperative Cobb angles of about 40 degrees. And if you looked at the most recent follow-up in these patients and utilized 30 degrees, meaning if you have a 30-degree curve, or natural history studies would suggest those patients are less likely to progress, 80% of our patients were less than 30 degrees at most recent follow-up. In the sagittal plane, these are two-dimensional evaluations. As you can see here, there really wasn't any significant change in the sagittal plane. I was hoping that we were recreating more kyphosis. We are looking at this with EOS in 3D, and we'll get more information on this as well. And as I stated, this is what formed the basis for the humanitarian device approval in August 2019. But not all the studies have been positive. Let's look at some of the other studies. Peter Newton, who had this study that he presented at SRS 2016, subsequently published in JBJS 2018, where there were 17 consecutive patients. Note that these patients were all RISR 0. 16 out of the 17 had open triradiate. So we like there to be growth, but what we're learning is if there's too much growth, that may get us as well. 9 out of the 17 in his cohort were considered to have a successful outcome, but he had a revision rate of 50%. And the point that I'd like to make here is that there's likely a sweet spot for growth remaining. You know, growth, as we know, it can help you, but it can get you as well, especially the parts of the spine that are not being treated. So the child that looks like this, triradiate open, with a milder curve, this child is likely not in that sweet spot. She's likely to overcorrect, have adding on or progression. The child that's RISR 1, Sanders 4, I think this is really the ideal patient. And then of course, the more mature patient, the RISR 5, Sanders 8, likely very limited, if any, role at all for vertebral body tethering. What are some other results that are out in the literature? Dan Hornschmeyer just recently published this. It was a smaller cohort, 29 patients, skeletally immature. He did have 2 to 5 years of follow-up. He had a wide variety of different Lenke types that he had in his cohort. And what Dan found was, again, if you look at that circled line of his main thoracic curvature, 46 degrees pre-op, and at 2 years post-op, and at most recent was 20 degrees. And 74% of his patients were less than 30 degrees at skeletal maturity. So if we count that as a success criteria, 30 degrees, about 75 to 80%, and that's been our results as well. We presented this paper recently at SRS, where we looked at, now we had 83 patients that had hit skeletal maturity. Again, preoperative Cobb angle now is up to 48 degrees because we were doing larger curves, but you can't let the curves get past 65, 70 degrees. At 2 years and latest follow-up, the curves are 21 degrees. But the key thing that we wanted to learn, and I wanted to highlight from this paper, is the reoperations, because as I stated earlier, yes, you may get a reasonable Cobb angle at skeletal maturity, may have some motion that's remaining, but this procedure, without a doubt, has higher reoperation. So in our cohort, it was 22% of the time. The vast majority of these patients, these reops are occurring for overcorrection. So proof of principle. Part of this may be our technical, the way we're doing the procedures, I'll show, but also we're probably doing patients that are a bit too young. So majority of these were for overcorrection. There were 3 patients that went on to fusion. So in our cohort, anywhere between 2 to 4%. I bet we're going to end up at right around the, a 5% mark that are patients that end up needing fusion even after vertebral body tethering. And that's important when we have discussions with families highlighting what the pluses and minuses are of this procedure. So let's focus in on the reoperations, because no matter what, if you do a reop in AIS, it hurts, right? If you do a reop, even quite honestly, if you're putting a magnetic rod in and you're reoperating, I mean, there's something as a surgeon, as a parent that is going to leave you unsatisfied. So I tell our families when I consent them now, you have to be ready that there may be an adjustment surgery. Most likely it's going to be for overcorrection. So here's an example of an overcorrection patient that we technically early on, we messed this one up because this patient had overcorrected on the table, right? This is an early result. And what happened is, because they're so flexible, even if you lay the tether or you tension it a bit proximally, you're already starting to throw that proximal part into overcorrection. Certainly undercorrection is a possibility if a curve is too stiff, and that's more of an indication. This is just not indicated in those stiffer curves, and we try our best not to do this. And then adding on, without a doubt, I'm going longer on my tethers now because I've certainly seen adding on if I don't get to at least the CSVL. Here's an example of too much growth, and we probably should have left a bigger curve. You can see pre-op, you can see the immediate post-op, the 1 year, by 2 years starting to overcorrect and required us to go back in and cut the tether. So, that really brings us to how should we be correcting the spine here? And we don't have really objective data. We don't really have gauge measures of how much compression we've done. But the key points that I really want to make sure is you have to select the patients correctly. Make sure that that curve bends under 30, 35 degrees. And on clinical examination, there's flexibility. When we're trying to decide how much detention, we're doing a balance of how much growth is remaining, which we're not great at predicting. We're looking at the magnitude and flexibility of the curvature, right? If the curve is larger, if it's 55, 60 degrees, I'm going to try to get it corrected more, and balancing that with how much growth is remaining. As a very general principle, you do want to compress those apical levels, get correction under fluoroscopy in the operating room to make sure that those are corrected. And then, as I showed in the previous example, make sure that those distal ends remain loose. So here's an example of an overhang curvature. As you can see, the CSVL ends up touching L3. On the table, we go ahead and get correction, understanding when they stand, there's going to be some loss of correction in that patient. So always make sure that you're going to make sure we understand that there's going to be some loss of correction, as you see with this patient here. This patient did have open triradiates, but had a larger curvature, and you still have to try to get that patient corrected because there's going to be some loss of correction as that patient stands up. Typically with growth, this patient will continue to show improvement. So here's a mistake that we had made. Of course, this was the daughter of a OBGYN. Here was a child that we had done a vertebral body tethering on. And if you take a look at that intra-op x-ray, today we would leave slack. That patient's already overcorrected, right? Between T11 and T12. You can see the disc is starting to reverse. And sure enough, as the child comes back for follow-up, by the 2-year mark is showing overcorrection, requiring us to release the tether. And my big advice is if you see overcorrection, particularly if it's causing any sort of a spinal imbalance and there's growth remaining, you want to jump on it early. The mistakes I've made are family will say, well, this is not really a good time. It doesn't work out. You have to jump on it, especially in a child that has a lot of growth. Otherwise, you can get some very severe overcorrection. Here's just a short video that I put in here showing our cord introduction and how we're going about tensioning the tether. The key points here are the grasper that we're utilizing. It's what's used to run the, that our general surgeons tell me that it will not damage the cord. It's used to run the bowel and for them to manipulate the lung as well, because you want to make sure that you save the integrity of the tether. We generally will introduce it from distal up to proximal. And what you're looking at is to your right is the patient's head. This is a right-sided tether. We've placed our screws. We're bringing our tensioning instruments one by one sequentially. We're going to be working our way down into the spine. And the key point is what we're doing right now is we will have a fluoro machine up, which is going to show us, and we want to make sure that apically that one really compresses those discs, because otherwise you're going to be left with very minimal correction. So you got to get it corrected across the apex. But on the distal end, have to be able to leave a loop. And there's a lot of different ways we can do this. You can do this by pulling some of the tether out, or we can do this through turning that distal tulip 90 degrees and then turning it back into plane. And that's what we ended up doing here, is we'll go ahead and twist a bit of that tether out. So again, because the key point is that you can see that those distal levels are already overcorrected. If you don't leave a loop, you're going to do, what's happened to us is you're going to see some overcorrection there. So what about mature patients, right? So we've shown that vertebral body tethering has a role in immature patients. What about patients that are older? And there are several groups that are operating here. Our general philosophy has been, you know, if there isn't growth left, you're not going to get growth modulation. And whether you call it anterior scoliosis correction, you know, tethering, but mature patients, I have a harder time. And, you know, some people will take, you know, this is actually taken off the internet. You know, it does have some, you know, massive patient recruitment because patients buy into this concept. We're going to need to see longer term results. But the concept is that you can take a larger curve, you can do disc releases, but in my mind, you may end up having pain, you may end up having a fusion later or fusion across those areas. It's going to require multiple surgeries without any doubt, right? Because that tether is not going to hold that curvature. You can do them 6 months apart, but going back in, especially if you have to replace an entire tether, at least thoracoscopically, in my experience, is definitely much harder, both technically and on the patient as well. And then eventually when the tether breaks, you know, you can do double tethers. What about stiffness? And why not just do a fusion on this type of patient is what our philosophy generally is. So, you know, we do get patients from all over and we want to try to make that shared medical decision, right? We want to be able to lay out what the pluses and minuses are. And this was a patient that had come to us, had gone to different centers, and people were advocating a tethering of the thoracic and of the lumbar spine. This patient was skeletally mature. These curves are high, but they really, really, really wanted us to do a vertebral body tethering. And you have to listen to the families. And they had these different, you know, options that they showed us that were offered, including doing, you know, a right-sided, left-sided double tether, changing it at 6 months, and then hoping that it would hold. And certainly one has to listen to families. But at our hospital, this is the operation she got because this is the right operation. A selective thoracic fusion, yes, she's still got a little bit of a lumbar curve, but in all likelihood in her, it's going to be one surgery. You're not going to be invading the lung. So our philosophy really is, and I want to reiterate, this is a very good operation, especially in the thoracic spine. Because the other thing that we're finding is that tethers do break and generally tend to break in patients that have not growth modulated. So if you don't have enough growth, haven't modulated, you're going to be at a much higher risk of breaking. So if you look at our data, you can see that there's this bounce back, right? At 2 years, it's 15 degrees. And then at most recent, it goes up to 22 degrees. That's because there are some tethers that are going to break. So what do we know about tether breakages from the literature? Well, Peter's paper that I showed a little earlier, 47% of the time he saw a tether breakage, and he defined a tether breakage as splaying of the tulips of the screws because the tether is obviously radiolucent, so you can't see it. In Dan's paper, again, about 48%. It's not that dissimilar from what we've seen in our series. But the key thing is the vast majority of the breakages, unless you're getting multiple breakages in a child that really didn't grow much and the curve comes completely back, are going to be asymptomatic. Often patients don't even know about it. You notice that splaying in the screws and you know that you have a breakage. Here's an example of a patient that we had where we saw this. Here's a 12-year-old child, pre-menarche, did have growth left, 58-degree right thoracic curvature. The curvature ends up increasing dramatically. We end up getting reasonable correction intra-op. And if you follow her out at the 5-year mark, if you take a look at those screws on the bottom more closely, you can see that they have splayed. So there's likely a breakage there. What the clinical significance of that is, we're not going to go back in for that because overall feel that she's gotten a reasonable result, but something to be very cognizant of, that breakages are going to occur. And what are some ways that we can try to avoid them? Well, as I stated earlier, they can be difficult to pick up. Typically means a greater than 5-degree change in the disc angulation. I've typically seen them in the distal thoracic and lumbar spine, and from time to time in the apical region, especially if patients haven't grown. And there's a couple of key things. You got to make sure that whether we align the screws. So for example, here you're looking at a lateral with the patient's belly to the right, back to the left. If we use that start point, you can see on that red line, I've actually already put a little break in there. That's going to put strain on that tether, and I think it's going to make it more likely to break. Where you really want to be is in line to help mitigate the chances of the tether breaking, even in children that have growth left. So here's a word on lumbar tethers, because that's where I feel tethering really ends up shining. So here's a child that had this double curvature, and this curve pattern for us typically today, i.e. a C-type curve pattern or a double curve pattern, I would have double tethered her. But at the time, we did a single thoracic tether. Now she's got a lumbar curvature, maybe not as much growth remaining. And I did end up tethering the lumbar spine in her, even though she had some growth, maybe not as much as I would have liked to have seen. So I strongly feel in the lumbar spine, unlike the thoracic spine, we should be trying to avoid fusion whenever possible, because we recognize, that we have to try to save levels, especially as we go more distal. We've done a couple of projects on this. So here's one where Michelle was the lead author, showing that as you fuse lower and lower down in the lumbar spine, the remaining discs have to take on more and more work. And as they're working more, they're much more likely to wear out. And that wearing out is manifested certainly with MRI studies. And now there's more clinical studies to show that it can lead to increased pain later in life. I touched on this shared medical decision making. And as you can tell from that other patient I showed you earlier, that was skeletally mature, that had a thoracic, a selective fusion. And we use this to a certain extent. And Noelle Larson is working with the FDA to really help define and develop a shared medical decision-making tool where you can look at what the pluses and minuses are. And families are very involved in that decision, but it behooves us as the care providers to make sure that we provide as accurate information when we don't have information to go ahead and state that. And where we are is we certainly recognize, lumbar fusions, down to L3, L4 particularly, long-term may have some deleterious effects, have to be able to have options. And for some families, one option will be better than the other. The few disc releases that were performed at our hospital, these were patients that would come into our hospital saying they're going to mortgage their house if they don't, get this done, at least for now, although long-term, we don't know. They have not had pain. And then of course, the pulmonary function, right? They have to understand that going in once may not have a big effect, but what about we go in a second time? And we're actively looking at that. We actually submitted a paper, an abstract this year, showing that probably even after the second surgery, at least in the younger patients, there does not appear to be a dramatic effect on their PFTs, but we're going to need much more data so families can truly make appropriate decisions. So let's come back to why we're considering anterior growth modulation. It's really the motion, right? That's really at the crux of this. That's what the families see. I want to try to save motion. And as I stated earlier, it's great when you do a procedure and then the family sends you this picture that shows, how well they're moving, how well they're doing. But, I have a number of colleagues that send me this from their thoracic selective fusion showing, listen, these patients move well as well. Of course, I've taken that picture off of the internet, the picture to the right, but it is a very fair question. And what we've been doing is really studying these patients in our motion analysis laboratory to really understand what the pluses and minuses are. And I know most of you are familiar with motion analysis. This is work that Ross Chaffetz and Josh Bays in our group are really heading out. And I can share with you what we're finding is, firstly, these patients, undergo a wide, we match them. We perform them on all of our fusion patients and our tethering patients. And then we determine what their motion levels are through a variety of different activities, flexion, extension, rotation. And this is a paper that we just submitted to JBJS. And what we're finding here is not surprising. If you look at how much loss of motion there is, the loss of motion for the posterior spinal fusion group in purple is much greater than for the tether group. It's interestingly, the L4 group here, these numbers are very small. So we'll see where that ends up, because that's where I truly feel when I see my patients is the biggest impact is when you compare an L3 or L4 fusion versus a vertebral body tether patient. In the thoracic spine, there's some difference, but not a whole lot. So in our opinion, a thoracic fusion, again, is a great operation. And this will just highlight that this is our approach. So this was, again, a child, an 11-year-old, has growth left, pre-menarche, triradiates closing, came in with these curvatures that had dramatically progressed. and really wanted vertebral body tethering. But in our opinion, this is going to be a much better option. And over time, not always, even with growth left, that lumbar curve, particularly if we get three-dimensional correction, is going to show some degree of correction as well. And again, this is a patient that we could certainly tether the lumbar spine. She has enough growth left if we don't get the result that we're looking for, but she's certainly well on her way. But that being said, this is where I think tethering really shines. 12-year-old boy with a thoracolumbar curvature, 48 degrees. This child would likely continue to worsen, get a fusion down to L3 or L4, and we try to avoid a fusion down there whenever we can. Here he's at 6 weeks, here he is at 1 year, 2 years. He's actually 5.5 years actually out now. And this is where I think tethering has its, potentially has its biggest impact. And then lastly, just to show you how much we've learned over the last 10 years and how much we still have to learn. Here's a 10-year-old boy, had a progressive curve despite bracing. And you can see we operated on him, he's one of our earlier patients. This patient is going to get overcorrect. Right? Look at his first direct. He's a boy, 10 years old. Today, I would have waited for that curvature and I wouldn't have corrected him to this point. And if you look at his growth chart over the years, he ends up growing almost 9 inches from the time of his tethering to his most recent. So, I'm following him every year very closely. Here he is at 1 year. I tell the parents, great family, gets it. Listen, we're going to go back in. I'm going to have to cut it, or we're going to have to replace it. Starting to overcorrect a bit. Here he is at 3 years. Maybe some slight overcorrection. And then at 4 years, I'm really surprised because he's grown quite a bit. And you can see these pictures coming through showing growth. And then at the 5-year mark, even though we thought he was going to overcorrect, he doesn't overcorrect. Now he's almost as tall as dad. And here's the lateral. So in summary, vertebral body tethering does offer an option to fusion, but it's, for select patients. And again, that's the way we have to view it. It's not going to make fusion go away, but has to be an option. There is going to be improved mobility, but it's going to come at the loss of predictability and a higher reoperation rate, which we have to do better as we understand tethering. FDA has been approved for idiopathic patients, but there are some other patients, and I didn't get into that in my talk today, that may benefit even more. And then, shared decision-making may allow us to push the indications as long as there's a clear understanding, but it is imperative, as we've learned from numerous examples, for us to continue to look at our data. And I will stop there. Thank you very much.
Amer, thank you. That was an incredible talk. You've really been a pioneer on the learning curve of how to do this. I feel like I'm just 6 patients in and very much on the intraoperative learning curve. A question I have for you, there are opinions out there where people feel that you can just put in a tether and you aren't burning any bridges. And I recently was referred a kid from Larry Carlin, who's an ambulatory Milo kid, 14 years old, who had about a 70-degree curve, was tethered and other things. And he comes to me, his tether's broken. He had a double tether, so he's got 2 screws in each vertebral body, and now a broken tether at age 14. Have you revised any of those kids to a fusion? And are those screws going to be an issue going posterior?
It's a great question, John. So we put in, when we did our most recent review, our IRB extended to 2019. And at that point, we had 7 patients that we'd already fused. That number is going to be closer to 12. We're going to redo it again. So what we learned from that, and I'll tell you my experience, and I'll tell you what our data showed. So my experience is, without a doubt, it is harder to place those screws, especially on the convexity. And what I do is I bring fluoro in and try to dodge, the anterior screw. Oftentimes you'll have to use a shorter screw as well, John, on that convexity. The spine, and I've got some videos of this as well, appears to maintain its flexibility, because that was a key question is, are you having some sort of autofusion? We did see some of that with stapling. They get this bony bridge that would grow. So I did not see autofusion. The procedure itself takes longer. The results appear to be the same. In our 7 patients, when we looked at implant density, it was very similar to our current implant density. Neuromonitoring, again, 7 patients, no real change. The operative time was without a doubt longer, John.
Great. Thank you, Amer.
Amer, this is Joe Bradke. Can you hear me okay?
Oh, yeah, of course. Yep, no.
Hey, thank you so much for coming. Really appreciate your talk. It's wonderful to see you. I had a question about sort of hybrid constructs. You made a great case for trying to limit fusion into the lumbar spine, and wondering if there are times when we might consider, or you've already considered, or you've already done maybe a limited fusion at the apex of a pretty tight curve, and then managing this sort of process above and below. Or what does that sound like to you? Is that viable or?
Yeah, Daryl. So absolutely, it's viable. The technology, there's some talk, could there be a short rod with a flexible tether above and below? To me, the biggest impact would be for in 2 scenarios. One would be that double major curve pattern, where you could potentially, and we have done this, fuse the thoracic, see how the lumbar does, and then tether the lumbar. But also in those overhang curves as well, right? Where you've got that 1AR curve that's shifting to the right that you have to go down to L3 because they're so shifted and the CSVL touches it, where you could tether, perhaps a little below the apex, maybe 12 or 1. I mean, you could fuse, down to 12 or 1 and then tether below it. I personally haven't done that hybrid construct, i.e. on the same side having a fusion/tether. But I know that there's groups in Turkey that have, and they've sent me some X-rays, and it appears to be promising. And I guess time will tell.
That's great. Thank you for joining us today, and thanks for all your work on this. Really excellent.
It's truly an honor, and what a great institution you guys have. I see that there's a question from Dr. Saltzman asking, do the tethers have variable? Right now, currently they do not. It is an area that's being actively, so there's one tether that's approved on the market right now, but there's going to be several that are going to come out from a variety of different companies. I know there's studies going out on in Europe. There's studies that have been started here as well. And my understanding also is that they're also looking at changing the material of the tether, firstly to make it radio opaque, and there's likely going to be a change in the biomechanical properties of the tether as well. Certainly the overall durability of the tether needs to be improved, and that may come through some of the different biomechanical.
Thank you.
Great talk. Oh, thank you. Here's another question. Is there a role for this in neuromuscular? So, John Smith asked the question, and I think if there's a child that's not ambulatory, where they have a collapsing curve, it is not going to, it's not going to work. I think it's going to be very difficult to be able to support, because that child is sitting down and collapsing into their curvature. The ambulatory myelo patient, where you're going to have to, otherwise you're going to have to go through the back. You've got all the wound complications you have. I actually feel comfortable with that patient population. They may need their thoracic motion more. I've had a couple of kids with phocomelia, no arms, no legs, where they need their thoracic motion that I've operated on. The curves, quite honestly, radiographically don't look great, but their function appears to be upheld. And so I do think in very select neuromuscular patients, particularly those that rely on motion, even a little bit of motion that may be preserved, that's where it has a big impact. Certainly in the phocomelia patients, we're going to end up putting those patients together and into a little short case series.
Any other questions for our visiting professor this morning? Otherwise, I think we'll wrap things up.
Great.
Okay.
Yep. Thank you very much, guys, for having me.
Many thanks. It's great
It's our
talk.
pleasure.
Thank you. Thank you.
Thank you.